So I'm delighted to introduce our speaker today, Dr. Anna Vaughn. Anna is based at the VA and is one of our outstanding educators. Won the top teaching award at the VA this past year. And Anna would like to talk to us today about dysphagia. So looking forward to a great talk.
All right, thank you very much. Thanks to all of you for being here, and thanks for that introduction, Dr. Hunt. I did all of my training at Emory, started at Emory Med School. I don't know if we have any med students here, and then stayed on for internal medicine residency. And now I'm at the VA, and one of the things that a theme that I started observing once I was in practice in hospital medicine was this theme of dysphagia and how commonly that was coming up in the patients I was taking care of and some of the corollary issues that had to go along with it. I realized that during my training I really had never really either been taught or considered the nuts and bolts. So started looking into it a little bit more in a little bit more detail, and I'd like to sort of take you on a whirlwind tour of my findings. No conflicts of interest or financial disclosures. So the learning objectives for this time are to recognize the importance of dysphagia and aspiration risk in the internal medicine patient population. I'd like to describe the major aspiration syndromes and summarize some important points in diagnosis and management. We'll define the physiology and the objective evaluation of dysphagia and identify some key points about benefits and burdens of tube feeding, which is a common conversation that comes along when we're dealing with these issues. So to start with a case, I've got a chest x-ray to post up here and test your chest x-ray reading knowledge. Does anybody notice anything unusual or abnormal? Excuse me, this is actually a chest x-ray. It's taken from the Images in Clinical Medicine series and from the New England Journal of Medicine of a patient who actually aspirated barium during a barium swallow. Now, the purpose of a barium swallow is not to outline the lower respiratory tract, but it does provide sort of a visual for what the physiology of what we're talking about. And so in that case, this particular patient was an 84-year-old man with coronary disease, AFib, COPD, congestive heart failure. He was admitted to the hospital because of a decrease in mental status. He was found to have profound hyponatremia and questionable lung infiltrates. The patient had a history of choking on food, difficulty swallowing, and had a history of recurrent pneumonias. So ultimately, his respiratory symptoms were managed conservatively. He got a PEG tube and was discharged to a nursing home. And I think this particular patient is illustrative for this topic because he represents so many of the patients that we take care of in internal medicine. He's got lots of comorbidities. He was admitted for altered mental status, and it really highlights the issues of identifying dysphagia and then the implications of tube feeding discussions. So aspiration, what is it and why is it important for internal medicine? When I first started looking into this and kind of putting together a talk, I mentioned to a colleague that I was going to be talking about aspiration, and she got all excited, thought we were going to be talking about the hopes and dreams of being an internist, and probably was a little bit disappointed to find out that what we were actually going to be talking about was inhalation of either oropharyngeal or gastric contents into the lower respiratory tract. Why is it important for internal medicine? I'd like to do sort of a little informal poll here, and at least for the folks here in the Emory auditorium, and kind of ask you just think back over the last month and think about patients you've taken care of. And we'll run through a list, and I'd like you to raise your hand if you've taken care of a patient with one of these illnesses. Head and neck cancer. Okay. How about stroke? Okay, keep your hands raised. Keep your hands raised. Parkinson's disease, ALS, multiple sclerosis. Okay, dementia. All right, I'm waiting for everybody's hands to go up. How about people with altered mental status because of hepatic encephalopathy, drug overdose, alcohol? Okay, well, I'm just going to go ahead and say most people raise their hands at some point during that. And what I just listed are medical conditions that are often associated with aspiration, as well as the conditions that often lead to an altered mental status and again, an aspiration risk. And as we've just demonstrated in this small room, it's a very common, we deal commonly with the patient populations who are at risk for this. So it's important to be able to identify aspiration syndromes, be aware of some of the severity of the outcomes that can happen, and appropriate treatment. So what's the connection between aspiration and pneumonia? Well, pretty much all pneumonias are actually aspiration, in that the bacteria that cause a pneumonia are essentially come from oropharyngeal secretions that make their way into the lower respiratory tract. But for what we think of as a typical pneumonia, it's typically a very small volume of material with typically a pathogen of fairly high virulence. The difference between that and what we think of as an aspiration pneumonia is that typically those pneumonias are caused by more of a large volume and sometimes more mildly virulent pathogens. But ultimately what we think of as an aspiration pneumonia is what results from impaired clearance mechanisms for protecting the lower airways. And sometimes these aspiration pneumonias can actually, in many cases, can actually have a more severe outcome than what we think of as more typical pneumonias. So this study took a look at hospitalized patients who were hospitalized for a pneumonia and divided them up. See, I don't have a pointer, but I'm just going to circle here. Divided them up into the patients that came in with an aspiration pneumonia and patients who came in with a non-aspiration pneumonia, and sort of looked at characteristics and including outcomes. And one significant note is that if you compared the aspiration group with the non-aspiration group, there was a significantly increased rate of intensive care unit admission, mechanical ventilation, and mortality. And you may notice that this is in regards to community-acquired aspiration pneumonia. There's similar findings were found for healthcare associated. So what are the pulmonary aspiration syndromes? Well, we think of aspiration pneumonia, aspiration pneumonitis, blatant airway obstruction, lung abscesses and empyemas. Exogenous lipoid pneumonia is when a substance that's aspirated over time is lipid-rich. It's a specific syndrome. Can lead to chronic interstitial fibrosis, mycobacterial pneumonias. But for the purposes of this overview, I just wanted to focus for a few minutes on aspiration pneumonia and aspiration pneumonitis. Starting with aspiration pneumonitis. It's defined as an acute lung injury following the aspiration of regurgitated gastric contents. So that's in contrast to oropharyngeal secretions or ingestions, and this is actually gastric contents that are then refluxing up and being aspirated into the lower airways. For those of you that are into eponyms and remember from medical school, this is sometimes known as Mendelssohn syndrome. Dr. Mendelssohn, believe it or not, was an obstetrician/cardiologist who described this syndrome in 1946 on a set of pregnant patients who were undergoing general anesthesia for obstetrical procedures. And ultimately, all of the patients in that particular series did really well. Excuse me. So aspiration pneumonitis differs from an aspiration pneumonia in that, generally speaking, in a normal stomach, the gastric contents are sterile because of the very high acid levels. So typically, we're not talking about bacterial pathogens, but the toxic effect of the acid itself on the lower airways. And essentially what happens is a chemical burn of the tracheobronchial tree, causing what can be very severe pulmonary parenchymal inflammation. Its clinical presentations can range from totally asymptomatic to mild respiratory distress, bronchospasm, in severe scenarios, pulmonary edema and ARDS. Because of the physiology of it being really a chemical burn, the recommended treatment is supportive therapy, up to and including mechanical ventilation if necessary. Antibiotics, as you can imagine, aren't necessarily indicated, although in a scenario like this, it's often unclear what exactly happened, what exactly is causing the patient's respiratory distress. And in an ill patient, it's entirely appropriate to start antibiotics when there's some question. Those can always be discontinued when the clinical picture is made more clear. It's worth noting that, like I said, in normal circumstances, gastric contents are sterile. But with use of PPIs and H2 blockers, that can artificially raise the pH of the gastric contents and make the patient be at risk for colonization of those contents, which then puts them at increased risk of a bacterial superinfection. Similar situation can be found in patients who are receiving enteral tube feedings, as well as small bowel obstructions, gastroparesis, anything that sort of allows more stasis in the stomach. So moving on to aspiration pneumonia. So it's a clinical definition and is defined as the development of a radiographic infiltrate in a patient with risk factors for increased oropharyngeal aspiration. I have an example here of a chest x-ray that was taken of a patient at 8 o'clock in the morning. You can see the lung fields look nice and clear. After the development of respiratory distress, about 2 hours later, we have a chest x-ray that now shows a right lower lobe infiltrate. And because this patient, I'm not sure who the patient was, but they were clearly at risk for aspiration, this was labeled an aspiration pneumonia. I'd like to talk a little bit about the clinical presentation of aspiration pneumonias and management. So because of gravity, there are fairly typical locations that infiltrates will appear in patients who have an aspiration pneumonia, and it really depends on what position the patient is generally in. In a patient who is recumbent, in the recumbent position, we tend to see the infiltrates appear in the posterior segments of the upper lobes, and you can see on this chest x-ray here the infiltrate there. Infiltrates can also appear in the apical segments of the lower lobes, as you can see in this picture here. However, in a patient who's upright most of the time and who will typically see more of the basal segments of the lower lobes, like the x-ray we looked at a few seconds ago. In terms of the clinical presentation, because of the microbiology of the typical aspiration pneumonia and the oropharyngeal contents, the course of the pneumonia tends to be more indolent than what we think of as a typical pneumonia, with the acute onset of shortness of breath, coughing, sputum, rigors, fevers, and chills. An aspiration pneumonia can present sort of in a more indolent fashion, tends to produce a very putrid sputum and produce a necrotizing aspect, or such as a lung abscess or an empyema, or pus in the pleural space. This is a gross pathology slide of a postmortem examination of a lung in which there was a lung abscess. So sort of a graphic representation of that different or the tendency of particularly anaerobes to produce more of a necrotizing presentation. So speaking of anaerobes, what is the microbiology of an aspiration pneumonia? So this pie chart is from a paper where the authors basically tried to identify a culture data on patients who were admitted with aspiration pneumonias, and then put it in this chart. So what's helpful about this slide is that it shows us a couple of important points about aspiration pneumonia. One of the things you'll notice is that the largest portion of the pie chart is no organism recovered, which is pretty typical for a pneumonia in general, where we don't have blood culture data, we don't have sputum cultures or BAL cultures that really grow anything. So we're really treating empirically. Another thing you'll notice if you're looking really closely is that from the slice of pie of patients that did have an organism identified, if you added up all of these organisms and put it in the pie chart, it will come up to more than 100%. And what I mean by that is that essentially there were more organisms than patients, which essentially means that there were polymicrobial pneumonias, which is also typical of an aspiration pneumonia. Finally, the study took a look at community-acquired versus hospital-acquired or healthcare-associated acquisition and found that for healthcare-associated aspirations, there was more likely to be staph involvement or enteric gram-negative bacteria. So let's look a little bit more closely at community-acquired aspiration pneumonias and the microbiology of those. Essentially, we're looking at the oral flora, and if you've ever wondered what germs live in your mouth, here's a list of them. And this particular list was generated in a study where they tried to define the normal bacterial flora of the oral cavity. And I can't really pronounce half of these organisms, never heard of half of these organisms. And essentially what's more helpful than thinking of the specific organisms is thinking of sort of the classes that they fall into. And in a community-acquired aspiration pneumonia, the three groups of organisms that are usually culprits and that we need to cover with antibiotics are aerobic, anaerobic bacteria, and a group called microaerophilic streptococci, which essentially is a streptococcus organisms that thrive in an environment with some oxygen, but not too much. Typically, they don't have a lot of clinical impact, except in this scenario, we find that they do actually make a clinical impact on these pneumonias. In contrast, a hospital-acquired or healthcare-associated aspiration pneumonia has a different profile, as we looked at a minute ago. So in this study, the authors took BAL samples from institutionalized or nursing home residents, elderly people who were admitted to the hospital with an aspiration pneumonia. And in the healthcare-associated group, they found that most were gram-negative bacilli, 21% anaerobes, and 15% staph. So the clinical implication of this is, what antibiotics do I treat my patient with? And of course, as I've mentioned, the site of acquisition is really important for thinking about which ones you're going to choose. For a community-acquired aspiration pneumonia, the recommended antibiotics are clindamycin, amoxicillin clavulinate, or metronidazole plus amoxicillin or penicillin. You might think, well, aspiration pneumonia, oral flora, anaerobes, why can't I just put the patient on metronidazole? Well, it turns out there's pretty high failure rates with treatment with metronidazole alone. And the thought is that the reason for that is that it does not cover those microaerophilic streptococci that I mentioned before. So that's why a penicillin is necessary in addition to the metronidazole. Any one of these antibiotics is recommended. There are some other antibiotics that possibly could be effective but are not recommended as first line: fluoroquinolones, macrolides, some selected cephalosporins. Duration of therapy, 7 to 10 days for an uncomplicated aspiration pneumonia, meaning no abscess or empyema, something of that sort. For your patient that is a healthcare-acquired aspiration pneumonia, essentially their colonizing bacteria become healthcare-associated bacteria and at risk for multi-drug resistant organisms. So the antibiotics that are recommended fall largely in line with the HCAP treatments that are recommended. And these are the IDSA guidelines for HCAP. Typically, what would be the best choice would be either choosing a carbapenem or a beta-lactam, beta-lactamase inhibitor, like piperacillin, tazobactam, because those two classes also have anaerobic coverage. And then adding on vancomycin or linezolid for your MRSA and staph coverage. So we've talked a lot about the aspiration syndromes, how to recognize them, what to do about them. But let's now take a step back and really get into the nuts and bolts of the mechanical reasons why our patients are presenting with aspiration syndromes. And for the most part, we're talking about oropharyngeal dysphagia. Dysphagia, or difficulty swallowing, can actually be esophageal in origin, but for the purposes of aspiration physiology, we're focusing on the oropharyngeal phase. If you'll remember from anatomy and neurology and med school, the machinery that our body uses for swallowing is quite complex. Swallowing is underestimated in terms of its complexity. We need to use our brains, nerves, coordinate breathing, muscles and tendons and cartilage of the head and neck, as well as the whole larynx and vocal cords need to be precisely coordinated in order to produce an efficient swallow. And as you can imagine, disruption of any one of those factors can have pretty significant consequences on the patient's swallowing efficiency. There's two phases of the oropharyngeal swallow. The oral phase is the preparation of the food bolus for swallowing. And you can see here this sort of bluey white area is the bolus sitting on top of the tongue. Tongue pushes the bolus to the back of the throat, whereupon it enters the pharyngeal phase. Both of these phases use cranial nerves 5, 7, 9, 10, 11, and 12, and are pretty complex. And generally speaking, what you see is the base of the tongue pushing the bolus back, the hypopharynx narrows, the epiglottis moves forward and then closes over the larynx, and then in normal scenario, the food bolus passes efficiently down the esophagus without entering through the vocal cords and down into what we tell our patients, down the windpipe. When those mechanisms are disrupted is when we start to get into pathology. And this is where our friendly speech pathologist is so very helpful. In most hospitals, the speech pathology therapists are a consult service. They can come see the patient at the bedside and do a bedside evaluation, which is essentially watching the patient ingest different consistencies of foods and liquids and seeing if there's any overt signs of aspiration. But whenever there's a question or it's a little unclear or there's suspicion of silent aspiration, then there's two main forms of objective evaluation that your friendly speech pathologist may recommend and do. And I think it's helpful to kind of understand those a little bit more in detail, because I think that helps us understand what's going on with the patient. So a flexible endoscopic examination of swallow, you may have heard referred to as a FEES, F-E-E-S, and that's essentially a laryngoscope where the speech pathologist inserts the laryngoscope through the nostril of the patient who's awake and alert and sitting up and visualizes the vocal cords while they are swallowing substances of different consistencies. You can't evaluate the oral phase of the swallow or the moment of the swallow with this method, but it really gives you a detailed view of what's going on when the patient, before and after the patient swallows at the vocal cord level. The second study is often used as a modified barium swallow study. This one is done in the radiology department. It's real-time fluoroscopy of a patient drinking different consistencies of substances mixed with a little bit of barium, and then the bolus is watched as it makes its way, hopefully down the esophagus. It's important to note that a speech pathology evaluation can give you more information than just pass and fail. They can identify varying degrees of severity of dysphagia. They can potentially recommend a modified consistency diet that may make the swallowing safer. And they can also recommend therapies for the patient, that certain swallowing techniques that may make their swallow safer and more efficient. So I'd like to show you a couple of videos of these objective evaluations. So we're going to start out by looking at a FEES study of a normal swallow. Let me pause it real quick. Well, let me go back to the beginning. I'll just identify where we're at. Nope. Here we go. It's a little hard to see, but basically we're looking at the epiglottis here, and then as we go farther, you'll see the false vocal cords and the true vocal cords down here, keeping in mind that just beyond the true vocal cords is the trachea. Okay, so as you can see, when the patient swallows, you can't see anything, but then you kind of see the aftermath. And what you can see in this patient is that there's a pretty efficient machinery going on here. The vocal cords are snapping together efficiently. with every swallow. The epiglottis is coming and closing over the hypopharynx, and really you're not even seeing the substance that the patient is swallowing. Okay, so contrast that with this video of a FEES examination of a patient who does not have a normal swallow. First of all, you'll see that we've got the epiglottis here. There's probably some edema here in the hypopharynx. This kind of green, gunky stuff is probably residual from the swallow test that they've been doing. Essentially what the speech pathologist does is a lot of times they put food coloring in with whatever substance the patient is ingesting so that they can actually see what's going on. So in this scenario, the patient's going to be swallowing something that's whitish. So we see them getting ready to swallow, and already you can kind of see that things are moving a little more sluggishly. Those vocal cords don't seem to be moving very effectively. Okay, now they're starting to swallow this trial substance. And you can see that now the entire area is essentially coated with this whitish substance. It's a little bit better view in just a sec here. Okay, let me see if I can pause it. So see how there's all this residual material here, which should not be here. It should be moving on more efficiently. If you look closer, you can actually see down into where the vocal cords are and down into the trachea. You can actually see aspiration of this substance directly into the trachea. The other thing to note about this patient is that this is an example of silent aspiration. So if you or I were having this test done and this white stuff was accumulating on our vocal cords, we would have a major coughing spasm. If you've ever inhaled a little bit of water while you were laughing or talking, you'll know that the reflex is immediate and pretty severe. This patient shows none of that. It's sliding right down into their trachea without their knowledge. So we've looked at a FEES. Let's look at a modified barium swallow. This is a example of a normal swallow. Both of the MBS studies are veterans from the Atlanta VA Medical Center. Let's see here. So you'll see it's a fluoroscopy, and we can look at it a couple times because this patient's swallow is so efficient that you kind of miss it if you're not looking. So let me pause it. I don't know if you saw it, but there's this dark bolus sliding down the esophagus, which is posterior to the trachea. So the trachea is out here, and we really do not want to see any radiographic material there, which we don't in this particular patient. However, in the next patient, who I believe is a survivor of both head and neck cancer and a stroke, what we see is movement of that radiographic bolus into the windpipe. Let's see here. They're getting ready to swallow. Okay, so if you watch as the bolus is going down, you'll see that some of it is sort of escaping and not going down the esophagus, but moving anteriorly into the trachea, and you can kind of see it going over the vocal cords. I can't really, I'm not really good at pausing this, but if you look closely at the very end, you can see a streak going all the way down from the vocal cords through the trachea. You'll also notice how slowly it's going down compared to our normal patient, which also shows that those mechanisms of the muscles and nerves contracting are not doing a very good job. Okay. So not to overwhelm you with a bunch of words on the screen, but essentially I wanted to kind of show you an example of a note or recommendations that a speech pathologist might leave for you as the medical provider. This is actually lifted from a note left in one of my patients maybe a couple of years ago. And I'm just going to highlight a couple of things. So on this patient, a FEES was performed revealing a severe oropharyngeal dysphagia. The risk of aspiration is high. The speech pathologist gave a few options that the patient could consider in going forward and dealing with how are they going to get nutrition in the setting of a risk of aspiration. The first and most sort of safe and most conservative approach would be NPO with alternative means of nutrition, aka tube feeding. Another approach might be to use a modified diet, dysphagia puree with nectar-thickened liquids for pleasure, with use of a modified supraglottic swallow sequence, which is essentially using a technique to make the swallowing efficiency more efficient and safer. They note here, as above, modified diet and safe swallow strategies may reduce that risk of aspiration, but do not eliminate it. And then finally, the patient may elect to take a liberalized diet, choosing consistencies as they wish, despite the high risk of aspiration. And ultimately, what our speech pathologist recommended was that this needed to be discussed with the medical team. The patient and family needed to be informed of these results, and then goals of care needed to be addressed. And intuitively, you can see that addressing goals of care is imperative for coming up with what the next step will be in terms of nutrition for this patient. So approaching the tube feeding decision. Dysphagia is often accompanied by questions about tube feeding, although it is not the only indication for it. And as you approach the tube feeding decision with a patient and their family, first of all, just want to highlight that you always want to think about the time frame of this patient's expected dysphagia. If they have something reversible going on, maybe they're overly sedated, they have an illness that is expected to resolve quickly, then they really wouldn't be a candidate for even considering like a PEG tube. So you want to really consider those things carefully before moving forward with thinking about tube feeding. Also, you want to gather your multidisciplinary team. So your speech swallow team we've talked about is super helpful in these circumstances. Palliative care is usually very well versed in these issues. The primary team taking care of the patient and any subspecialty consultants who are involved and may have some input as to the illness that the patient has and how that will impact their nutrition. And then finally, making sure to address goals of care. I put in this proposed algorithm. It came from a paper in The Lancet back in 1997. It was put together as sort of an attempt to try to come up with an ethical guideline for who to offer a PEG tube to and who not to. And just briefly, they talk about anorexia, cachexia patients, people with cancer, cachexia, permanent vegetative state. But just to highlight at the bottom here, in the setting of dysphagia without complications, meaning the patient's generally healthy, but has some sort of dysphagia that prevents them from getting adequate oral nutrition, let's say like a esophageal stricture that can't be fixed, then this proposes that a patient would benefit from a PEG tube and that this should be offered and recommended. However, if the patient is considered to have dysphagia with complications, it becomes more complicated. And those are patients that have multiple comorbidities, other reasons why their nutrition is decreased and they may not be getting adequate oral nutrition. And in that setting, it's patient equivocally benefits from PEG, potential exists for loss of quality of life, and ultimately this leads to the recommendation that this really just needs to be discussed on a case-by-case basis with the patient and their family. So how do we approach that? I'd like to break that down just a little bit more. This study done in 1998 took a look at hospitalized patients in the U.S. who underwent PEG tube within the course of a year, followed them for 3 years, and just basically looked at the outcomes, trying to sort of sort out who benefits, who doesn't. And they list here all these diagnoses that the patients carried, and ultimately about 80% or most of the patients did survive up to 3 years with the PEG tube in place. but there remained about 20% that really did not even make it 30 days after PEG tube placement. And in fact, many patients don't even make it out of the hospital after the PEG tube is placed. So it brings up this question of what is that subset of patients that's going to benefit from a PEG tube, and what's the subset that I want to be wise in recommending it or offering it. So in 2007, a clinical guidelines was published. It's called the Rochester Community-Wide Clinical Guidelines Initiative, sort of a consensus set of guidelines from many, many experts in review of the available literature. And it tried to sort of break down some of this decision-making for both patients, their families, and the healthcare providers helping them with this decision. So essentially looks at some of the major illnesses that lead to feeding tubes being discussed, how they impact survival, how they impact quality of life, and whether they would potentially enable a cure or reverse the disease process itself. And this is really more for the patients and families to sort of make that very clear. And if you look at it kind of overall, what I've done is label red or sort of pinkish is where PEG tube is not likely to be beneficial in this area. In the greeny blue boxes represent where a PEG tube is likely to be beneficial. And then yellow is sort of kind of dependent on goals of care and other specifics that we can talk about a little bit more. So I'd like to kind of briefly look at a couple or a few of these diagnoses in a little bit more detail and just highlight maybe a couple of the studies that led to these conclusions. But mentioning that in any patient who undergoes a PEG tube placement, there's a lot of burdens that they need to be considerate of prior to getting into that. Sometimes patients need to be restrained either physically or with medications, especially with dementia patients that want to pull tubes out. So ultimately that becomes a burden. Often admitted to the hospital with infections related to their tube. And then just GI distress, vomiting, diarrhea, constipation, nausea. Those types of things are very common in patients with PEG tubes, as well as PEG complications themselves, or dysfunction, obstructions, infections, bleeding, leakage, peritonitis. For patients who had a stroke, we know that PEG tube placement does prolong life for patients who were previously in good health, and even for patients who were previously in poor health. And what that means is essentially a large burden of comorbidities or not. However, what about quality of life? So this particular study looked at a group of patients who underwent PEG tube placement. The majority of the patients in the study turned out to be stroke patients, who was a larger proportion of those. And what they did was they looked at baseline functional nutritional status, well-being, and then compared that at 1 year post-PEG placement. And this is a lot of noise on the screen, and I don't mean for you to look at all the numbers, but what I wanted to just point out is when they looked at the baseline measures of functional status, nutritional status, self-reported well-being, and then compared them to a year after the PEG tube was placed, there really was not any significant difference. So the quality of life post-PEG was not improved for the majority of these patients who had had a stroke. Now, for patients who were previously in good health, have minimal comorbidities, and had dysphagia from their stroke, about 25% will regain their swallowing function and ultimately can get the PEG tube removed. So there's certainly a subset of patients that will have increased quality of life, but it's beneficial to sort of rehearse that there are patients that will not. Looking at ALS, Lou Gehrig's syndrome, we know that feeding tube placement will definitely prolong life in these patients. It certainly doesn't reverse the disease process, and it really depends on the patient as to whether that fits with their goals of care, whether their quality of life will be improved by that or not. In patients with a persistent vegetative state, again, it will prolong life, does not reverse the disease process, and in general does not improve the quality of life because these patients are unable to experience life. Skipping down to advanced dementia, because this is a very common diagnosis that we deal with. Basically, the literature shows that we don't have any evidence to show that PEG tube placement in a patient with advanced dementia prolongs life, improves quality of life, and certainly doesn't reverse the disease process itself. A study was published in 2012 on the Journal of American Geriatric Society that specifically looked at survival in PEG tube placement in patients with advanced dementia. It was a prospective cohort study, took a look at all U.S. nursing homes, over 36,000 patients or residents in nursing homes that had advanced dementia, started having new problems eating. Almost 2,000 of them had a feeding tube inserted. So this study looked at how those 2,000 did in comparison with the rest of the cohort. And essentially the survival curves matched completely. There was no evidence that the patients with the feeding tubes lived any longer. And because of this and other studies, the number one recommendation in the ABIM's Choosing Wisely campaign for geriatrics is don't recommend percutaneous feeding tubes in patients with advanced dementia. Instead, offer oral assisted feeding. And this is based on both survival as well as quality of life assessments. Talking about advanced cancer, another commonly encountered large diagnosis, there really isn't any evidence similarly to prove that in patients with advanced cancer that placement of a PEG tube prolongs life or improves quality of life. In the American Society for Parenteral and Enteral Nutrition guidelines, they did a really thorough review of nutrition support therapy in all sorts of cancer patients. One's undergoing surgery, one's undergoing chemo. When they looked at the studies that looked at malnourished patients that were undergoing some sort of treatment, ultimately there was no survival benefit associated with any nutrition support intervention, although there were some smaller variables that showed improvement. But big picture-wise, survival benefit was not found. Similarly, and even more limited evidence to show that nutrition support therapy and palliative care in patients in the advanced stages of their cancer in the dying process did not show any benefit from feeding tube placement. Did want to note one very specific exception to this generalization, and that's head and neck cancer, because by very virtue of the cancer itself, the treatment that will either cure or improve the patient is highly associated with oropharyngeal dysphagia, and thus poor nutrition during treatment, which thus leads to less response. So surgery, radiation, chemo, they all affect a head and neck cancer patient's ability to take an adequate oral intake. So in many of these patients, if the time period that they're expected to have significant reduced oral intake due to the side effects of the treatment is anticipated to be of any significant duration, such as a few weeks or longer, then often they are recommended to get a PEG tube either prophylactically before they even start their treatment or once the treatment has gotten started. So just to circle back and just kind of take a visual look at this chart that does show in many, many disease processes that patients are not likely to benefit from PEG tubes, although there are very specific and good examples of patients that will. Finally, before I wrap up, I wanted to take just a minute to talk about some frequently asked questions that often come up when we're having these discussions with patients and their families. So one thing that you might wonder is, well, we have a patient, they're at risk for aspiration, they've even had an aspiration pneumonia. Does putting a feeding tube in actually reduce the risk of aspiration pneumonia? Theoretically, you would say yes. In truth, actually no. Funnily enough. Just as an example, the European Nutrition Society guidelines for enteral nutrition did sort of a review of the literature on this topic. And just to kind of take one piece out of this table and take a look at these numbers. So they looked at patients who had an aspiration pneumonia, got a PEG tube, and then looked to see if they had an aspiration, or the percentages of people that had an aspiration pneumonia thereafter. And what you can see, 58%, 58%, 15, 53, 49, 51, that the percentages of patients experiencing an aspiration pneumonia before and after PEG tube placement were either very similar or worse. Possibly, there's a lot of factors that may explain this. It may be that patients become more immobile, more bedbound, and more recumbent with the placement of a PEG tube. It increases hospitalizations and complications. And so there may be multiple factors that are leading to this practical result of a feeding tube not really preventing aspiration pneumonia. The other thing to remember is that while a patient who's at risk for aspiration, while they get a feeding tube in and now their nutrition is going in through their stomach directly and bypassing their swallow, their oropharyngeal secretions are still there and still can cause pneumonias. Another question that comes up, I think quite often, especially in the setting of advanced dementia, is do feeding tubes help prevent the development of pressure ulcers? The thought process here is increasing nutritional status, increasing skin integrity, decrease pressure ulcers. Again, counterintuitively, it has not been shown that they do. Similarly, do feeding tubes help heal pressure ulcers? And this is one where I find this discussion comes up quite frequently in our practice, is we have a patient, usually with advanced dementia, they have some significant pressure ulcers and not eating very well, aspiration risk. And the question becomes, if we place a feeding tube and try to help optimize this patient's nutritional status, maybe that will promote wound healing. And ultimately, what the literature tells us is that is not the case either. So sort of a groundbreaking study on this particular topic was published in the Archives of Internal Medicine in 2012. This was a propensity match cohort study. Took over 1,000 nursing home residents who did not have any pressure sores and had a feeding tube inserted for probable aspiration risk or difficulties with eating. Took 461 residents who did have pressure sores and had a feeding tube placed, matched them up with residents of similar comorbidities, age, and comparable risk factors, and looked to see, in terms of skin integrity, how everybody did. For the group of patients who did not have a pressure ulcer to begin with, when they received a feeding tube, the percentage of patients who developed ulcers was significantly higher than the percentage of patients who did not have a feeding tube placed, an odds ratio of 2.27. Conversely, the patients who had a pressure ulcer to begin with, who had a feeding tube placed, in terms of the improvement of their pressure sores, there were less improvement in those patients with the PEG tubes than those without the feeding tubes. So what we can gather is that a nursing home resident with a PEG tube is more likely to develop a new pressure ulcer, and a nursing home resident with pressure sores is actually less likely to heal if a feeding tube is placed. And again, this probably goes back to some of the same factors that play into the aspiration pneumonia question. So we've come to the end of our whirlwind tour of dysphagia, aspiration syndromes, and tube feeding decisions. I hope that we've made the point that it's important to identify aspiration syndromes in our patients to treat them correctly and keep potential severe outcomes in mind. Also, that oropharyngeal dysphagia, hopefully we've sort of unlocked a little bit of the mystery of oropharyngeal dysphagia, and I'd like to encourage you to have a low threshold to recruit your speech-swallow team to get involved in those patients' care. And finally, that overall, it's important to keep goals of care, the big picture, in mind when considering a feeding tube for your patients. Important to meet with the patient and their family and a multidisciplinary team and use the evidence that we have to think through the pros and cons of this very important decision. So I appreciate your attention during this talk. I'd like to quickly thank Christina Huffman-Shipp, one of the speech pathologists at the VA, who very kindly let me use some of her slides and help me with this. Tammy Quest, Scott Aiken in the palliative care area, Leslie Miller, one of our general medicine colleagues at Grady, and Dr. Dan Hunt, Division Director for Internal Medicine, for Hospital Medicine. Thank you very much.
Thanks for that great overview. Open it up for questions, and if you have, please use one of the microphones. We would appreciate it. I'll start off. Recommendation number 2 on your slide talked about training, swallow training as a mechanism for enhancing. Does that really work? Is there good data? Obviously, it depends upon the syndrome that's associated with the dysphagia, but can you comment more on that swallow training?
Swallow training. So just as an example, like for instance, a patient who might have facial hemiparesis of the face and neck muscles from a stroke, there's techniques that maybe they might use, such as moving their head to the side to utilize the muscles that do work and sort of neutralize the muscles that aren't working whenever they swallow. Something like that will improve the efficiency of the swallow. To be honest with you, I don't know the answer about how effective those are. I do know that in the stroke population specifically, that those techniques actually don't have any bearings on outcome and reducing those risks, but I'm not sure about outside the stroke population. Any questions in here or any of the other sites? Yes. Does occupational therapy help with swallowing recovery? I think, now this is just me sort of making the connection. I don't know of any data specifically. I think in general, improving deconditioning in patients is always better overall for their functional status and would have sort of an indirect impact on it. But I don't know, and it may be that there are studies, but I don't know of any that show that occupational therapy specifically, other than the realm of speech and swallow therapy, has any impact. All right. Thank you.